last speaker of the day, and somebody who will thank me no end for being the last thing between you and a beer, is Nigel Cross. So you've already been introduced to him earlier today, but I'll tell you a little bit more about him. This is the man that you can blame or thank, I don't know, depending how you look at it, for me being in perfusion. He was the one that taught me at university when he came in. He then actually examined my practical exam, and then took me to the pub, and then gave me a job at Great Ormond Street when he was chief there. So it's all down to him, so bad or worse. So you can either clap or go, oh, for God's sake. Anyway, it's his fault, yes. But as you heard, he retired a little while ago, and I often wondered, well, what do perfusionists do when they retire? Well, apparently, they go and put the dogs on bypass. So here we go. Perfusion, it's all gone to the dogs.
Thank you, sir. This is a sort of perfect talk for the end of a day, especially when there is beer and whatever on offer. There is a warning with this. There will be pictures of cute dogs. Also, it's not actually just retirement. I've been doing it for about 10 years. To put it into context, my eldest daughter is a vet. Whilst she was in training, she had a lecture on diagnosing and managing cardiothoracic problems in animals, specifically dogs, canine. It was suggested that the college were going to set up or they were actually in the process of setting up a surgical treatment for mitral valve disease. It's the one that we do the most of. At the end of the lecture, she said, do you have a human perfusionist or do you have a veterinary perfusionist? And Dan said, well, we have a human perfusionist. He's called Fred, and he wants to retire, and we don't know where to get another one from. And Emily went, I might have the answer to your problem. Why have you done that? Okay, let's go. I'm going to introduce you to Tom. Tom was an 18-month-old Labrador Retriever, beautiful looking dog, presented with congestive heart failure, lethargy, murmur, really poor prognosis. He had a mitral valve repair with Professor Dan Brockman, and then a fantastic surgeon from Japan called Sumi Yuichi. We'll come back to him. That's Tom. Bless. That is post-op next day. Looking good. I always have two questions. Why? Which is a reasonable question. And how much? So the why, it's just a dog. Why would we, why waste resources on a dog? But this is the US, because you're a nation of dog and cat lovers. Who owns a dog? Whoa, okay. Who carries an insurance? Not so many, okay. 60% of you own dogs, which is about 45% of the households, and on average you spend £1,700 per year on that dog's care. It's a lot of money. So why not? These dogs will die. They will die of congestive heart failure if you don't operate. It's pretty binary. You can offer them surgery or not. How much? We charge £23,500. That's all in. That's about a 10-day package. We estimate about 70% of our admissions have insurance. 15k of cover for a year will cost you £125 a month. Sorry, 15k of cover means per admission, so you'll get cover up to 15k. Veterinary practice isn't cheap. My daughter says her common complaint is that vets are ripping people off. They're not. It's just that in the UK, nobody knows how much medical care costs because it's all free. For instance, the Brompton, if you wanted to go privately, it's 35.5 grand, and that was a couple of years ago. The myth is that all of our clients are rich. This is a patient arrived at the Royal Veterinary College. We've got a big green field outside. Arrived in the Augusta. rather lovely looking Ridgeback. You arrive in your Gucci handbag. You go back to your yacht in the Mediterranean. Sorry, you know, folk we try for a consult, well, reception might not be too good because we'll be in the middle of the Mediterranean. Oh, that's nice. And please don't mess with my hair because I've just had it done. But in reality, clients will do anything for their animals. They will remortgage their houses. They will borrow. We have a lot of American clients. And what's your 410 something or other? That one. They'll break into that and pull money out of it to pay for it. And they become true family members. They are considered true family members. And there's a huge amount of guilt if you don't do everything you can for your pet. Even though a successful outcome may only mean another couple of years of life, because these dogs don't live forever. Queen Mother Hospital for sick animals. Other hospitals are available. Japan are the world leaders. They're in Yokohama. Their center, Professor Yuchi's center, they will do 8 cases a week. And most of their, I won't say most, but a big percentage of their clients do come from the States. Here in Florida, you have the University of Florida Veterinary Center, the small animal hospital. We're trying, it's difficult to work out how many we're doing or they're doing. It seems to be a bit cagey about it, but it's one a week, but not every week. It's a proper hospital. Sorry, it is a proper hospital, but it's also a proper university. It's quite a famous Royal Veterinary College. It's quite a famous college. It's open 24/7, 365 days of the year, about 7,000 admissions. Obviously, more cardiac. They cover the whole spectrum. Orthopedics, ophthalmology, spinal, we have an A&E unit. We have an on-site canine blood bank where you can get FFP, MPR, packed red cells. Can't get platelets. They don't keep very well. I don't know why. You can get feline blood. It doesn't store. So you have to amass relatives of the cat to donate blood. So it's the same sort of group. They have multiple cats have multiple blood groups. Disease, it's really similar to those in the human pediatric population, possibly genetic coding and breed design. Brachycephalic dogs. Brachycephalic dogs are the dogs that look like they've run into a brick wall and have flat noses. They have all sorts of problems because it's bred into them. Does anyone have a Cavalier King Charles Spaniel? That's good. They are particularly prone to mitral valve disease. And it's also aging. It's just like you and me, well, me specifically. We're kind of wearing out and our valves pack up and the cords go. It is breed specific. DCM is also significant. Don't get a Doberman because it will probably have DCM. Presentations. Dogs really hide their symptoms. It's a survival instinct. If you're ill, you are prey in the animal world. So they will hide their symptoms. So by the time they get to us, they're in really poor condition. They'll have dyspnea, ascites, failure to grow, depression. I'd love to diagnose depression in a dog. Sorry. And they will have a murmur. Well, obviously they'll have a murmur. It's mitral valve disease, but sometimes you don't need a stethoscope. This should run. I don't know if it will. There we go. You can see it. And if you put your fingers on it, you don't need a stethoscope. You can just feel the thrill. Oh, don't do that. There we go. Anesthesia, pre-med, people say, oh, how different is it? It's actually not that different from humans. Methadone, stoned dogs look really funny. They will lean against you. Their pupils will be out like this. I love you, man. Induction, midazolam, propofol. Intubation, that's pretty cool because we haven't got a we've got a 90-degree bend. Dogs don't. Tube just goes straight in. Maintenance, propofol, nisoflurane on bypass. arterial access and venous access for monitoring purposes can be difficult, tricky sometimes, and you can use the tail, which is odd. Pre-op, stone dog, you can tell it's stone, mouth open, panting, pupils like, and then Cavalier King Charles, so it's lined up. There's your pulse oximeter. Is that arrow working? Oh, it's not. Never mind. Pulse oximetry on the tongue, obviously, because they're covered in fur and they can't see through fur. Perfusion, keep it simple. I went in there as I work at Great Old Street. I know what I'm doing. Doesn't really work. So you learn quite quickly. It just needs to be simple, mainly because at Great Ormond Street, the techniques we used worked because we did it all the time, whereas they're obviously they only do it once a week, or at the time they were only doing it once a week. So everything's new to them. The equivalent weight range is neonate to small adult. Standard circuits, 100, 101 oxygenators, cardioplegias 4:1. Well, it's 4:1, but we make it 1.5 times the strength. We were lucky enough to buy a reasonably highly discounted rate, a fairly brand new S5. They only made a few of this S5 because it was a direct precursor to the Essence, and then they brought the Essence out. This was lying around in an office. We got it for half price. Oh, that's a pump going round and round. Well, we all know what they look like. Prime, you probably can't read it. I'm always interested right across the front of the front of the Aquafarm 11. It's twice as the expense because it's veterinary, but it's exactly the same as human harms. And it does say suitable for, I don't know if this will work, whether you can see it. Probably not. Yeah, suitable for horses, cattle, dogs, cats under veterinary supervision. Some of them say rabbits, guinea pigs. It's like, however, we have a slight problem with it. You'd say it's a neonate, it's a 3 kilo Chihuahua. Well, you should put some blood in the prime. I did that, or have done that, and you go away for a cup of coffee and you come back and the prime looks like that because the red cells hemolyze. I suspect it's because canine red cells aren't quite as robust as human ones. And I suspect the Hartmann's because it's the plasma-like, because it has to cover horses to guinea pigs, doesn't match every species properly. And it's the only time when you'll be mixing bulk amounts together. We can get blood though. And what I like about the blood is that it has the donor's name on it. So it's not an anonymous number, it's a name. And this is Rufus. This is Rufus, a very fine Italian Spinoni. Difficult to say that, and you'll find out why. And this is Rufus getting the full attention of the transfusion girls. It looks like he's enjoying it, as you probably would do if you were being hugged. Please, if you do ever consider providing your dog for donating blood, it's worthwhile doing. It usually comes with the bonuses. Well, certainly at the Royal Veterinary College, if your dog donates blood, you will get a 1-year annual MOT, take your dog in and they do the works for free. Don't tell your dogs, though, that if they donate blood, you can give it to cats. You can't give cat blood to dogs, but you can give dog blood to cats. Canine aorta is extremely fragile. I suspect it's because we stood up and the heart in us is suspended to a certain extent on the aorta, so it has to support a certain amount of weight. In dogs, it doesn't because it's cushioned by the lungs. Cardioplegia needle's really risky. We've lost several dogs because it dissects just from the cardioplegia needle. Primary venous cannulation is the right atrium. Aortic cannulation is the carotid artery. This is a dog, and this is its circulation. Woohoo! Of course, they don't have superior and inferior vena cavas because they're not standing up. So they have, if I could use the phrase head end and arse end, I knew I couldn't do that. Oh, never mind. It says cranial and caudal vena cava. This is, well, oh, you could say this is an ECMO cannulation. This is a canine carotid. They've got a few, actually. You can sacrifice a canine carotid and they don't notice. Possibly because they're really stupid. The big pipe at the top is obviously the venous cannula. It's a fair way around the back. The needle is going into the aorta. So it's a pretty long way around. I forgot to say, it's not a sternal incision. It is a left thoracotomy. If we're doing mitrals, it's a right thoracotomy. If we're doing tricuspids, which we do occasionally. We aim for 100 mils per kilo. Ooh, that's low. How am I doing for time? I don't want to run over because the beers are on the way. We aim for 100 mils per kilo. People say that's really low, and it is really low. But it seems to work. However, we are not subjecting these animals to a huge barrage of neurological tests afterwards. It seems to be tolerated well. We go down to 28. I think that's too cold, but Dan feels comfortable with it. I'm trying to educate him on the possibility that we could do this a bit warmer because we do actually know what we're doing now, and we don't get into trouble too often. Keep an eye on your electrolytes. They are very sensitive to low calcium. Cardioplegia works or it doesn't work, or it kind of works. Some of it may be down to the fact that because the aorta is so fragile, they are frightened of putting the cross clamp on properly. You know, it'll go to one click, but it won't really go to the 3 clicks that you might need. So perhaps that's leaking a bit, or perhaps there's something about the circulation that it's getting back, or we're getting retrograde. Don't know. Sometimes that only lasts 3 minutes, or we just keep giving it. It's okay. And we will give a hot shot if we can. Keep an ear and eye out for your colleagues, because as well, I don't do it every day anymore, but there was a time when it was. We do this every day, and they don't do it quite as often, although weekly now and sometimes bi-weekly, them not so much. So they do get quite excited, and they forget to ventilate coming off bypass, and they occasionally like to give protamine whilst on bypass. And sometimes actually we have to put the cannulas in before we go on bypass. And hey, at the top is the heart and whole condition, cross section of it. Structurally, they're not all that different. The aorta follows a different path because it has to go that way rather than anyway. See the mitral valve. I told you to be cute pictures. Mitral valve repair is the most common thing that we do. We don't do anything clever. There isn't a mechanical valve we can put in because they don't make them that small. It's a suture annuloplasty. Just put a long Gore-Tex suture around the outside, put it up tight. We do a TOE pre-op. I love the TOEs we do. We have speed cardiologists. You can't get an echo on a dog without doing it quickly. So instead of that half an hour of, oh look, twiddling around for endless hours trying to, which you get, go away, let's get on the job. It's speed echo, which is really nice. Sorry if any cardiologists are here. And then we replace the cordite with Gore-Tex sutures. This may or may not work. On the left, it's it's sequential left to right. Pre-op, immediately post-op, and then about a week post-op. What are you laughing at? I'm sorry. I'm sorry there's no color on it. Because anyway, and also the heart remodels really quickly. It's pretty much this. I'm pointing at this screen and you're going, what are you pointing at? To your left, pre-op, and then immediately post-op, and then about 6 weeks post-op. If we do put a valve in, anticoagulation is a problem, which is why we don't put valves in anymore. This is a mechanical valve that's been put in. It didn't last very long, and that's what it looked like at post-mortem. So, we do pulmonary stenosis. You could call it tetralogy of Fallot, but it's usually just a really tight right ventricular outflow. So we make a big hole in it and we put a patch on it and we leave everything else. Dogs really compensate very well for VSDs and things like that. Not a problem. Right atrial myxoma, series of 1. It looked like some alien thing. When we took it out, it looked like that. It was the only one we did, but it was very successful, as you can see here. The surgeon's on the left, by the way. Recovery. If you get off bypass, it's really nice. If you give protamine, it's not so nice. It's the only major difference between humans and canines. They do not tolerate protamine. Don't know why. So we have to give it very slowly over about an hour. We give 50% over half an hour, and if the dog's still hemodynamically stable, that's a good thing. If there is any if there's any instability, we will stop the protamine, wait for a bit and let them recover, and then give the rest. Patient will be extubated on the table, will be returned to ITU awake, self-ventilating. When they do well, they do really well. This will be next day. Scratchy little thing, but quite sweet. That's the most important thing to see them do, is drink. If they don't want to do that within 12 hours of being awake, it's probably not going to have a good outcome. 24 hours. Sorry, that's me, by the way. And then 8 days post-op. Fat Chihuahua. Chunky Chihuahua. We're doing well. To break down what we're doing, in 25 to 22, done 209 mitral valve repairs, survival to discharge 166. A lot of this is driven by social media, because we have American clients and European clients. They talk to each other. There's a website for dogs with mitral valve disease. If you have a couple of deaths and you're only doing 100 cases a year, your mortality rate has a big spike, and then that gets reported, and then nobody comes. And it's currently, I think we're at 96% survival. But it is staged. The American College of Veterinary Internal Medicine class them as B1, B2, C, and then D. So we will operate hopefully on dogs somewhere between B2 and C. If we get them at D, they're not well. They're really not well. Pimabandin is a drug of choice. It will extend their period before they need surgery. And it's fairly obvious if we don't do anything, they will die. If we do something, they do pretty well. Things I have learnt. Dogs pant. Oh yeah, of course they do. Dogs pant, but dogs also pant when they're fully anesthetized. It doesn't disappear. So when you're rewarming, if you get it ever so slightly too high, which makes the surgery a bit tricky. Whatever. Don't be too clever, because we don't do very many of them, and every time changing things is quite subtle because we don't know, we've got no reference points. Small, good research, randomized trials, no. 100 mils per kilo, it's not a high index flow, but it seems to work, because basically if it's a squeaky ball post-surgery, all right, I'll rephrase that. If it's still a squeaky ball post-surgery, then we've probably done quite well. That makes sense, doesn't it? Yeah. We did look at our own data. This has just been published. And it was basically because we got, like I say, it's not blinded, it's not whatever. It's just going back, looking at our own patients, and we were trying to work out, were we getting better over time? It's a pretty close-knit team. It doesn't change very much. Did it get better the more we did? Yes, it does. I mean, it follows the sort of curve that you'd expect to see in a proper learning curve. It goes up like that. So we're quite proud of that. It's also one of the few published papers on mitral valve repair. Well, basically, because there are only 3 centers in the world doing it. So, yeah. Remember Tom? Long time ago now. This is Tom. This is Tom 6 months after his operation. Him and his buddies having a good time. Tom would like to say thank you. He's no longer with us. He died a couple of years ago, but he died of old age. He didn't die of mitral valve failure or congestive heart failure. So he'd like to say thank you. You'll see why. Because Rufus passed away a couple of months ago. He was an immensely stupid dog. I mean, he wasn't. I have to admit that the unit I transferred and transfused him to the other patient made the other patient 50% more stupid as well. So, but he was a nice dog.
Hi, my name's Chris. So I know Gibbon operated on dogs originally in the 1950s and then improved and had a bunch of challenges and then went to humans. But now that we're back to dogs from the full circle, what do you find to be the hardest challenge on modern bypass for canines?
Ooh. The hardest challenge, I think, is that we do so little of it. And it would be, we're trying not to be in our own little silos, to go back to Bob's reference earlier on, but it seems to be happening. It's very difficult to get information from Japan. They're quite cagey about their results. I'd love to see more collaboration between, there's only really 3 centers that are doing it, and that's here in the RVC and Japan. Japan are the leaders by a huge amount because of the numbers that they do. The only suspicions I have is that their success rate is 98%, 98.0%, and it's been 98.0% for 10 years. Now, statistically, I don't think that happens, does it?
It does if you fit the figures.
Yeah, well, that's true.
Thank you.
When you publish about dogs, is it like obligatory to put embarking in the title?
Oh, we're going down the route of the puns, and I can't think of one. Help me, Richard.
I hope the postdoc course wasn't rough.
What? Rough? Oh, yeah, that's true. Yeah, roughly, yes.
Somebody said that in the chat comments too.
Okay, so I have a question.
Sorry, I'm going to take the lead on this one.
When I was a perfusion student, I ran into a perfusionist that did heart surgery on horses, which made sense because, hey, if I've got like a $100,000 horse or a multi-million-dollar horse that's running in the Kentucky Derby, that makes sense.
As far as I'm aware, I don't think a horse has ever been put on bypass, but they do sort of non-invasive. You can call it heart surgery, I guess, because the press would call it heart surgery. Unless you know different, you'd need 1, 2, 3, 4, 5 oxygenators to run a horse.
Wow.
So that's 5 oxygenators, 5 pumps. Or as my daughter said when I said, why don't you go into looking after horses, race horses, because then you could keep me in the manner to which I'd like to become accustomed. And she said, well, looking after race horses is really boring. are not much fun as a vet because you watch a horse and if it doesn't walk properly, you shoot it. And if it doesn't breathe properly, you shoot it. And that's no fun. I've put cats on bypass. Cats don't really like surgery. Just put it that way.
Thank you.
It surely has to be, let's go and get changed and have beer time. I'm very flattered that there are so many questions. It's like, ooh. Sure.
I'll go while they fix the microphone. In our lifetime, do you see the use of temporary mechanical support like ECMO or something on a dog?
I have, of course, been asked the question, to which my reply was, why would you want to put a dog on ECMO? There is a reasonably valid reason, and the dogs will get pneumonia and the pneumonia will kill them, but they only get it for, there's a sort of crucial 24, 36-hour period. They get over it really fast, but dogs don't like being ventilated for that period of time. You could argue that you could put a dog on ECMO for a day and a half. I guess who'd be running it? But realistically, no. No. I think the whole of healthcare is resource intensive to suggest that you'd use some of those resources on your favorite pet might not be the right thing to do. I don't know.
All right. So the question I was going to ask was, in a country where healthcare is essentially free or included with taxation, and you're asking these families that love or these families are asking you, what can we do? And, it's going to be 23,000 pounds up front. I know you have reasonably high success rates according to your slide there, but how do you handle that when the dog doesn't make it?
We have a robust consent.
Yeah.
We treat these animals in the same way that you would treat humans. Well, not the animals, because you can't ask an animal for consent, but the dog's owners, their expectations are managed. And Dan will be very pragmatic about it and say, our success rates are at the moment 95, 98%, but I can't guarantee it. And your dog is in a higher risk group, and the owners will accept those risks, even though there's a financial cost to them.
Thank you. I'm a few years away from retirement, but I look forward to more talks from you so I can explore options for when that comes.
Thank you very much. Thank you.
Are there any more questions? I think the session has gone from the sublime to the ridiculous, but it's been great, I have to say. Thank you so much, my friend. It's a pleasure to have you over here.